Now that we reviewed the parameters for the normal ECG and looked at some tools, tips, and techniques for ECG interpretation, we're going to look at some common rhythms that you may encounter in your practice. And we're going to look at these from the lead 2 perspective.
Normal cardiac conduction begins when an impulse is initiated within the SA node. The SA node is considered the dominant pacemaker of the heart. Normal sinus rhythm, also called regular sinus rhythm, is considered the normal rhythm for a healthy heart at rest. Using the 5-step rhythm method, you can see that the ventricular rate is between 60 and 100 beats per minute. The rhythm is regular. The QRS duration is less than 0.12 seconds. The atrial activity shows normal appearing P waves that are upright, round, and consistently shaped. The P to QRS relationship reveals only one P wave for each QRS complex, with the PR interval measuring between 0.12 and 0.2 seconds long. An easy way to quickly identify a normal sinus rhythm is to apply the 3 to 5 rule. This rule states that if the PR interval is between 3 to 5 small boxes long, then it measures between 0.12 and 0.2 seconds and is considered normal. The triplicate method states that if there are 3 to 5 big boxes between the R to R intervals, then the ventricular rate is calculated at 60 to 100 beats per minute. Another sinus rhythm occasionally observed in young or healthy individuals is a sinus arrhythmia. Sinus arrhythmia is very similar to normal sinus rhythm, except that there is a rhythmic slowing and speeding up of the rhythm. The ventricular rate may vary, but is typically between 60 to 100 per minute. The rhythm is irregular, and each R to R interval will vary slightly in length. By observing the patient and the monitor simultaneously, you will notice that the rate speeds up with inspiration and slows with expiration. The atrial activity shows normal P waves. The P to QRS relationship has a 1-to-1 relationship with a PR interval between 0.12 and 0.2 seconds long. Any heart rate below 60 per minute is labeled a bradycardia. Sinus bradycardia in a healthy person may be considered normal and is often the result of exercise and good health. But for a person with a heart compromised by disease, a slow ventricular rate may not provide an adequate supply of blood. Bradycardia in the presence of disease may be associated with low blood pressure, an altered level of consciousness, or poor skin perfusion. The criterion for sinus bradycardia is a ventricular rate less than 60 per minute. The rhythm is regular with upright and normal appearing P waves. The QRS complexes are narrow and less than 0.12 seconds wide. A P wave is associated with each QRS complex, and the PR interval is between 0.12 and 0.2 seconds long. Any rhythm with a ventricular rate above 100 per minute is called a tachycardia. Sinus tachycardia may be a cardiovascular response to situations such as fever, hypovolemia, dehydration, pain, or fear. Sinus tachycardia may indicate a heart condition such as congestive heart failure. Using the 5-step method, sinus tachycardia will have a ventricular rate of between 100 and 150 beats per minute. The rhythm will be regular. The QRS duration will measure less than 0.12 seconds. The atrial activity will show normal and consistently shaped P waves. The P to QRS relationship will reveal only one P wave for each QRS complex, with a PR interval between 0.12 and 0.2 seconds. Sinus pause, sometimes called sinus arrest, occurs when the sinus node stops firing. A sinus pause will be noted on the ECG when an extra long isoelectric line is seen between the T wave of the complex and the P wave of the next complex. A sinus pause can last from 1 to many seconds in duration. Complete absence of sinus node or ventricular activity is called asystole. Asystole is seen on the monitor as an uninterrupted horizontal line. Asystole is usually the terminal rhythm in cardiopulmonary arrest. A low voltage setting or an improperly connected lead can result in a straight line on the ECG monitor, showing a false asystole. True asystole is always accompanied by pulselessness. Always check for a pulse when you see asystole on the monitor. Another form of asystole is called ventricular asystole. Ventricular asystole occurs when P waves are seen without any QRS complexes. This indicates that the sinus node is firing without any response from the ventricles. Thousands of cardiac pacemakers are inserted into patients every year. Pacemakers can be inserted into the right atria, the right ventricle, or both. The function of a pacemaker is to initiate an impulse when the heart's normal conduction system fails to provide an impulse in a timely manner. Most pacemaker rates are set between 60 and 80 beats per minute. The term capture is used when a pacemaker spike is seen on the monitor with an immediate wide QRS complex. Newer pacemakers are designed to sense the need for an impulse. Therefore, patients with pacemakers may display only an occasional pacemaker spike or may be completely dependent on the pacemaker for every complex.
Sinus rhythms can be placed in one of three categories based on their ventricular response. Regular sinus rhythm is between 60 and 100 per minute. Sinus bradycardia is any sinus rhythm less than 60 per minute, and a sinus tachycardia fires at a rate from 100 to 150 a minute. Now we're going to step the program up just a notch. Make sure that you know your 5-step rhythm method. If not, refer back to your book, because we're going to take a look at some dysrhythmias.
Early or premature complexes are called ectopic beats. Ectopic beats can originate within the atrial, junctional, or ventricular tissue. To analyze rhythms with ectopic beats, always start by applying the 5-step method to determine the underlying rhythm. Next, isolate the premature complexes and label them as atrial, junctional, or ventricular premature complexes. Atrial ectopic beats are called premature atrial complexes, abbreviated as PACs. A PAC is caused when a portion of the atrial tissue outside the SA node initiates an impulse before the next sinus impulse. Normal P waves may be seen or they may be hidden in the T wave. The QRS complex is typically narrow and will resemble the QRS complexes in the underlying rhythm. Premature junctional complexes, or PJCs, originate from an irritable portion of the AV junction. A PJC is an ectopic beat that initiates an impulse before the next sinus impulse. PJCs can be identified as early beats that have no observable P wave, or by inverted P waves with a PR interval of less than 0.12 seconds. The QRS complex is typically narrow. Premature ventricular complexes, or PVCs, are easily identified by their wide and bizarre configuration. When PVCs originate from a single site within the ventricles, they will have a similar appearance and are called unifocal. When there is more than one irritable site within the ventricles, PVCs will vary in their appearance and are labeled multifocal. PVCs that appear in pairs are called couplets. A run of 3 or more is called a salvo. A PVC may or may not have an associated P wave. The P wave may be buried within the complex or may be seen as a notch in the ST segment or T wave. The hallmark of PVCs is that there is usually a compensatory pause. This pause allows enough time for the sinus node to take over again as the dominant pacemaker. When an ectopic pacemaker overrides the sinus node, many different dysrhythmias may occur. Some of the dysrhythmias that may originate within the atria are atrial tachycardia, atrial flutter, and atrial fibrillation. The clinical significance of these rhythms is directly related to the ventricular rate. Let's apply the 5-step method to atrial tachycardia. The ventricular rate is greater than 150 beats per minute. The rhythm is regular, and the QRS complexes are typically normal and less than 0.12 seconds long. P waves may be seen or may be hidden in the T wave. Sometimes you may observe the rhythm suddenly change from a slower rhythm to an atrial tachycardia. This is called paroxysmal atrial tachycardia. Atrial flutter is easily identified by the picket fence waves that occur between the QRS complexes. The ventricular rate may be fast or slow. The ventricular rhythm is typically regular, but may be irregular. The QRS complexes are typically narrow and less than 0.12 seconds wide. There are no sinus P waves. Atrial flutter waves have no relationship to the QRS complexes. Atrial fibrillation is commonly seen in the elderly and in patients with congestive heart failure. The ventricular rate may range from slow to very rapid. The rhythm is usually irregular. The QRS complexes are often narrow and less than 0.12 seconds wide. No discernible P waves can be seen, as the baseline between each QRS complex is chaotic and wavy.
Coronary artery disease can result in a decrease in oxygenated blood flow to the myocardium. The result can be myocardial ischemia, injury, or infarction. Worst case scenario, your patient will go into cardiac arrest. And on the ECG monitor, you may see ventricular tachycardia or ventricular fibrillation.
Ventricular tachycardia has a ventricular rate of between 100 and 250 beats per minute. The rhythm is usually regular, with wide and bizarre-looking QRS complexes that are greater than 0.12 seconds wide. P waves may be seen in or between some of the QRS complexes, but are not associated. Ventricular tachycardia will not always generate a pulse. With or without a palpable pulse, VTAC is considered a life-threatening dysrhythmia. Ventricular fibrillation is a life-threatening dysrhythmia that is found in 90% of cases of sudden cardiac death. Ventricular fibrillation occurs when numerous ectopic impulses cause chaotic and disorganized depolarizations of the ventricles. No QRS complexes or P waves can be seen. Only a wavy, erratic line will be seen on the monitor. VFib never generates a pulse. So far, we have reviewed the ectopic beats of premature atrial, junctional, and ventricular complexes. Next, we will discuss atrioventricular blocks and escape rhythms. We will conclude with scenarios and rhythm strips. By using the 5-step method, you will be able to identify many different ECG rhythms. Injured or diseased tissue can delay or block electrical impulses traveling along the cardiac conduction pathway. The degree of block depends on the location and severity of the damage. A first-degree block is caused by a delay in conduction through the AV node. The ventricular rate is usually normal, but may also be bradycardic and less than 60 per minute. The rhythm is regular. The QRS complex is typically narrow and less than 0.12 seconds long. The P waves are normal in appearance and configuration. There is a one-to-one relationship between the P waves and the QRS complexes. The distinguishing trait of first-degree block is that the PR interval is greater than 0.2 seconds long. Second-degree blocks are divided into categories Type 1 and Type 2. Second-degree Type 1 is also called Wenckebach. Conduction through the AV node is progressively slowed with successive QRS complexes until eventually a QRS complex is dropped. The ventricular rate is usually between 60 and 100 per minute. The rhythm is irregular. A key factor in identifying this rhythm is to look for the dropped beats. By looking at a long segment of this rhythm, you will see groups of beats. The QRS complexes are usually narrow and less than 0.12 seconds wide. The P waves are consistently round and upright. Another distinguishing trait of second-degree Type 1 is that the PR interval starts out with a normal duration and then progressively elongates until the complex is dropped. A brief pause will be observed and the cycle starts over again. Second-degree Type 2 is a more serious block, as the tissue damage is located lower in the AV junction or bundle branches. Using the 5-step method, you will find that the rate is usually normal with QRS complexes that are typically less than 0.12 seconds wide. The P waves will be upright and consistently shaped. The hallmark of this rhythm is that some of the P waves do not conduct QRS complexes. This can be seen when the rhythm contains more P waves than QRS complexes. When P waves conduct QRS complexes, the PR interval may be normal or greater than 0.2 seconds, but the PR interval is always constant. Third-degree block is the most serious of the heart blocks and indicates a complete blockage of impulses between the atria and the ventricles. Using the 5-step method, you will see that the ventricular rate is slower than the atrial rate. To discover the difference in rate, you must calculate both the rate of the QRS complexes and the rate of the P waves. Both the QRS complexes and the P waves will have a regular rhythm. The width of the QRS complex depends on whether the lower pacemaker is originating from the junction or from the ventricles. A junctional pacemaker will have QRS complexes that are less than 0.12 seconds wide. A ventricular pacemaker will display QRS complexes that are bizarre and wider than 0.12 seconds. The P waves will be consistently shaped and normal in appearance. Since the pathway between the atria and the ventricles is completely blocked, there is no relationship between the QRS complexes and the P waves. When injury or disease renders the sinus node incapable of initiating impulses, or when impulses from the AV node are blocked, another pacemaker site must take over. The AV junction and the Purkinje fibers are capable of pacing the heart. These backup rhythms are called escape rhythms. Escape pacemakers will usually pace the heart at an automatic or set rate. The rate of each pacing site is 60 to 100 beats per minute for the SA node. The AV junction paces at 40 to 60 beats per minute, and the Purkinje fibers pace the heart at 20 to 40 beats per minute. Using the 5-step method, a junctional escape rhythm will have a rate of 40 to 60 beats per minute. The rhythm will be regular and usually have narrow QRS complexes that are less than 0.12 seconds wide. The atrial activity will reveal inverted P waves that may be before or after the QRS complex or hidden within the QRS complex. If the P wave occurs before the QRS complex, the PR interval will be abnormally short and less than 0.12 seconds long. The features of a ventricular escape rhythm are that the rate is less than 40 beats per minute and the rhythm is regular. Impulses for ventricular escape rhythms originate in the Purkinje fibers. This type of conduction is slow and will generate wide QRS complexes that are greater than 0.12 seconds wide. P waves may occasionally be seen but have no relationship to the QRS complexes. Ventricular escape rhythm is sometimes also called idioventricular or agonal rhythm.
Accurate diagnosis of the ECG rhythm is more important than a hasty guess. If the patient is unstable, you'll need to take action immediately. If the patient is stable, you'll be able to go bedside and do some more assessment parameters. You may even have time to do some diagnostic tests. The ECG stands at the center of your patient care.
Now that we've discussed the criteria for basic dysrhythmias, let's practice with some scenarios and rhythm strips. When learning to interpret ECGs, it is important to take enough time to systematically evaluate each part of the rhythm. Remember to apply the 5-step rhythm method to each strip. Connie is a 27-year-old nursing student preparing for her board exams. She states she has not been sleeping well and has been drinking 6 to 8 cups of coffee a day. She is generally healthy. Her only medication is oral birth control pills. She arrives at your clinic complaining of dizziness and intermittent palpitations since this morning. Her vital signs are pulse 180 and regular, respirations 26, blood pressure 102/62. Upon placing her on the ECG monitor, you see this rhythm. The correct interpretation is atrial tachycardia. Your next case is Mr. Buchanan. Mr. Buchanan is a 72-year-old retired engineer. You're preparing him for a hernia operation scheduled for the next morning. He has a history of myocardial infarction 3 years ago. He takes digoxin and Lasix. His vital signs are pulse 90 and irregular, respirations 20, blood pressure 160/84. On the monitor, you see this rhythm. The correct interpretation is atrial fibrillation. You are working in the emergency department late one evening when the rescue squad arrives with an unconscious and unresponsive elderly man. CPR has been in progress for approximately 10 minutes. The patient is transferred to the gurney. You place him on the monitor and you see this rhythm. You confirm that the leads are attached properly and see that there is only a coarse, wavy, chaotic rhythm. There are no ventricular or atrial beats observed. The correct interpretation is ventricular fibrillation. You are working the urgent care clinic when a 25-year-old woman is brought to your clinic complaining of dizziness and chest palpitations. She is 22 weeks pregnant with her first child. Her pulse is 198, strong and regular. Respirations 24 per minute. Blood pressure is 102/56. Her only medication is prenatal vitamins. Upon placing her on the cardiac monitor, you see this rhythm. The correct interpretation of this rhythm is atrial tachycardia, often referred to as SVT, supraventricular tachycardia. Mr. Simpson is a 42-year-old